Hello, good morning. Plus, if you can hear me, um, drop a comment on the comment section that you can hear. So I'll be waiting until I see the first comment. Hello, if you can hear me, you should. If you can hear me, just let me know in the comment section that you can
Hello,
hear.
if you can hear me, you should. You can hear me.
All right, thank you very much for your comments, Saratin and Yusuf. So we are going to start with the first case study. I remember when I was taking your class, I gave us information about diuretics. I told us about loop diuretics and each of those diuretics. I gave you the points where they act. I remember in the class I told us that there are some diuretics they are not supposed to take together. So this particular case study one, we are just going to do about 5 or 6 case studies because it's a short class because it's just the first time. After that, we'll take an assessment. All right. So the first case study is a diuretic case study, which says Mrs. Ade, 65 years old, is admitted with acute heart failure, presenting with severe dyspnea. Who can tell me what a dyspnea is? Please do not search ChatGPT as your phone. Just type what you know, and then I'll see how accurate it is. Presented with severe dyspnea, bilateral crackles, and triple pitting edema. So if you know what a dyspnea is, you can drop it in the comment section. And I'll see. Okay, difficulty in breathing. So thank you very much. So that is it. So the physician orders furosemide 40 milligram IV starts. I remember telling you that furosemide is a loop, and then it occurs as a loop. And I described that definition on the board. I also described told you the fact that there's also a particular part of the nephron that's referred to as a loop of Henle, and that is where most reabsorption of electrolyte takes place, and that place is usually blocked when you take loop diuretics. Okay, so it means that this doctor wants a drastic reduction in blood flow. Now, what is the reason for the drastic reduction in blood flow? When there is congestive heart failure and there is a dyspnea, which is accumulation of fluid, which is struggling to breathe as a result of accumulation of fluid, you find fluid gathering in the alveoli, which will now make it difficult for gaseous exchange to take place. And as soon as difficulty of gaseous exchange takes place, you find this patient finding straining to breathe. All right. So the vial contains 10 milligram per ml. So let us see the question. So question 1, calculate the volume to be drawn up. And then question 2, state the maximum rate of the IV. State the maximum rate of the IV state the maximum rate of the IV administration for furosemide and explain why this is critical. Now, I told you that there's a reason why, or there's a need for us to do case studies. Now, when you do case studies, we're able to see scenarios or information that we missed out in class. Usually not your fault, probably the fault of the lecturer, but it's easier for us to identify issues, unique cases in case study, and then address it. Do you understand? So question 3, what is the unique mechanism of action that makes loop of Henle more potent than thiazides? All right, now potency is the effectiveness. All right, that's the comparison. So remember I told you that thiazide act over a long period of time, but furosemide, when compared to the half-life of thiazide, furosemide is going to give you a drastic reduction in fluid faster than thiazide. So let's do question 1. So calculate the volume to be drawn up. So remember the concentration of the drug. The concentration of the drug is the concentration of the furosemide was given as 40 milligram IV start, and the vials contains 10 milligram per ml. So although there's not a blackboard here, what you just do basically is you take that 40 milligram divided by 10, and you're going to get 4 ml. So what you're trying to do, you're trying to get the volume of the ml you administer to the patient. So if you know the answer to any of the questions as we are reading it, you can just state it, and I will see if I can comment or correct. All right. Thank you very much, Sadiq. Yeah, Sophia, you mentioned it. All right. So look as mentioned that 4 ml. So that is correct. That is the IV, the infusion you are going to IV you are going to administer to the patient because of the concentration of the vial of the furosemide. So state the maximum flow rate of IV. Now, I didn't mention this in class. The reason why I didn't mention it was because most of all these informations are unique to a particular drug. I just taught you general as a class. So when you're administering furosemide can cause a severe side effect known as ototoxicity, okay, which is hearing loss. All right, and if it's administered too fast, that is what causes the ototoxicity. So what you give furosemide over a slow period of time. All right, you give it over a slow period of time, You understand? Over a period of maybe 1 or 2 or 3 minutes, you don't give anything less than, you don't give it less than 1 minute. If not, you are going to the patient is going to develop hearing loss. So many nurses can make this mistake when they administer the drug. Sometimes some doctors too. All right. So what is the unique mechanism of action that makes loops more potent than more potent than thiazide? So loop diuretics, what they block is that they block the loop of Henle. I mentioned it. This is where majority of the sodium reabsorption takes place. You understand? So meanwhile, thiazide, on the other hand, they don't block this loop of Henle. Do you understand? They block it different parts of the nephron, or usually in the distal, the later end. I think I drew the nephron for you in class. And I think, I don't know if I showed you how thiazide exactly works, but thiazide blocks the later ends of the loop of Henle. You understand? So what is the next question? List three key assessments the nurse must perform before administering the first dose. So class, I remember telling us that there are some signs, there are some important things that those electrolyte does do in the body. For example, I told you some of the electrolytes are responsible for contraction of the heart. So if furosemide is causing them not to be reabsorbed, it means that there's going to be a problem with that particular patient, especially when it comes to their cardiovascular physiology. So before any patient administered furosemide, there are some things you have to check. First of all, you have to check the vital signs, which is blood pressure, heart rate, respiratory rate. You have to check that first of all. You have to check their serum electrolyte. You have to check the electrolyte that this person have, especially the potassium electrolyte. You understand? You have to check their renal function. This patient's renal function is working very well. I don't know if you understand. Then you have to check their weight. Now, why do I say weight? Because furosemide is going to make this patient lose drastic fluid, and therefore it's going to impact on the general overall weight of this patient. You don't want to make this patient become underweight because of the administration of what furosemide. So usually when you consider all of these factors, it can either impact the dose or impact the choice of another drug, or generally inform you better on how to monitor this patient closely if there is no other option but to give furosemide. So allergy, furosemide also is a sulfur drug. Furosemide is a sulfur drug, and therefore it comes with some peculiar allergy. All right. So so what are the adverts? 2 days later, the patient's potassium level is 2.9. The normal is 3.5 to 5.0. So whenever I give you a question like this, especially number 1E in the exam, what I expect from you to know or for me to do is that I want you to compare whatever figure I give to you with the standard I will give to you. Definitely, I will always put the standard there. Any prescription you see, any doctor information you see, any laboratory test you see doing electrolyte balance, they always give you the normal rating. You are not supposed to cram any of these figures. You understand? So don't bother about it. So when I tell you 2 days later the patient's potassium level is 2.9, while the normal range is 3.5 to 5.0, name the adverse effect. This is just simple hypokalemia. This number 2E question is a giveaway. All right. Then 2 nursing consideration that you should do. First of all, you withdraw the drug. Hold the next dose. Don't give the next dose of the furosemide. You understand? Then you monitor heart rate and monitor blood pressure rate. Then also you can also give potassium-rich foods. I don't know if I taught it in the class. You see, who is this Esther? Did I tell you to write your mark number on the group? Have I ever started collecting attendance? Please advise this girl to delete her mark number, please. Thank you very much. Or Esther, if you can hear me, just kindly delete it. I don't know if I mentioned in the class that one of the ways to replenish potassium when a patient is losing it is to do what? Is to be on potassium supplements. And we know a very good example of potassium supplements is banana, potassium containing fruits, banana. Then potassium supplements you can buy them in the pharmacy, it can be recommended. However, there's also a chance of what? Hyperkalemia, which is worse than hypokalemia. So in hyperkalemia, all you just have, or in when a patient is coming down with hyperkalemia, of course you will notice when you're monitoring the level routinely, and then you quickly alert the doctor for the necessary things to do. All right, so that's that for case study 1. These are the answers, but I'm not going to leave this answer for you. We are just going to move on to case study 2 immediately because of time. So now, case study 2, we are going to be testing our knowledge on ACE inhibitors. Mr. Chidi, please somebody inform Esther to delete her mat number so I don't end up, I don't remove her from this meeting. So Mr. Chidi, 52 years, started enalapril. Now, enalapril is an example of ACE inhibitors. ACE inhibitors, when I taught it in class, I told you that they prevent the conversion of angiotensin 1 to angiotensin 2. Then they therefore inhibit the angiotensin converting enzymes. And I know I did not mention it like this, but I think I will have to update that information where ACE enzymes, angiotensin converting enzymes, what it does is that it helps to break down bradykinin. Bradykinin, when it's not broken down, accumulates, especially when the ACE enzyme has been inhibited. When the ACE enzyme is inhibited, the bradykinin in the body is going to continuously increase. And then it gets to a stage where it increases and then start causing irritation in the upper respiratory tract and lead to persistent cough. And that cough usually worsens at night. Okay, I didn't mention this part about it worsening at night. I don't know if I did, but it's going to help us in answering questions from this case study. So Mr. Chidi, 52 years old, started enalapril 5 mg daily for hypertension 10 days ago. So he calls the clinic complaining of a persistent dry cough that is worse at night and disrupting his sleep. So he does not have fever, he does not have sputum production or chest pain. All right. So now this patient does not have any of the signs and symptoms that will lead to interpreting that he has infection or he have any upper respiratory tract disease. So now let's see the questions. What is the unique mechanism of action that causes ACE to produce dry cough? I mentioned it already in the introduction of this question. So what is the unique mechanism of action is that ACE inhibitors will inhibit ACE enzymes, and ACE enzyme is the reason ACE enzyme is responsible to break down bradykinin. And when bradykinin is not broken down, it accumulates because ACE enzyme has been inhibited. All right, and eventually, because of that accumulation, it then starts to irritate the upper respiratory tract, which causes dry cough. All right, that worsens at night. Okay, so that's the answer to that. What percentage of patients develop this side effect? I told you in the class about 15%. So generally, the range is about 10 to 20% of patients will come down with 10 to 20% of patients will come down with this dry cough, and usually common to people from Asia population. That's people that are in Asia, although it's common in Africa, but it's usually common in Asia. Not that it's not common in Africa, it is. I've seen patients who have cough associated with onset of ACE inhibitors. All right. So, but it's more common in Asia population. Does not mean that we do not have it here. So just note that. Then stage two ways to differentiate between ACE inhibitor dry cough and stage 2 ways to differentiate between ACE inhibitor induced cough from a respiratory infection. So first of all, I mentioned that ACE inhibitor are dry, non-productive cough, no fever, no sputum. That is, this patient keeps coughing without bringing out anything from the mouth. You can't even form sputum. You can't form spit, what we call spit. You can't form it. All right. Meanwhile, a respiratory infection, upper respiratory tract infection, will be productive. There will be productive cough. There will be fever. The sputum will be colored yellow, and the rest. Okay. Then, usually, in cases like for ACE inhibitor, it usually happens within the period of introduction to ACE inhibitors, usually from about 1 week to 6 months. So if this patient has been taking ACE inhibitors for the past 7 or 8 months, in case I twist that case study, you know that definitely is not ACE inhibitor induced cough, because the cough did not start within 1 week to 6 months when the patient started it. All right. So ACE cough also are persistent, that they don't stop. You can keep coughing. The patient can keep coughing from 0 seconds to 30 to 40 seconds, non-stop, and the person is not coughing anything. Usually very irritating and embarrassing. All right. So usually those coughs, you just use that to identify that. But there's no kind of cough, except the patient is asthmatic. But actually, asthmatic will also produce sputum, and you will see the wheezing sound and the struggling for breathing there while they are coughing. But in AC, because every other part of the body is normal, it's just in the embarrassing cough that is there. So what is the most appropriate management for this patient cough? I told us already in class, the only management for the patient's cough is to withdraw the drug. That is, you remove the drug, you take away the drug from the patient. So let me ask this question. Okay, I don't think it's here. If a patient is reacting to ACE inhibitor's cough, like is having ACE inhibitor-induced cough, what is the next best class the patient can use? Who can recommend? Who can let us know? I think I mentioned it in class. What is the next best class the patient can use? I will just allow the 20 to 30 seconds for that question. What is the next best class the patient can use? All right, someone that said AROBs. Okay, let's see another person's comment. AROBs. Okay. AROBs. Are you guys copying? Are you copying? What's the name? Yusuf. Okay, now what are AROBs? Please type it in full. What is AROBs? Please, Yusuf, do not type. Let me see. Which other person is going to type AROB? Precious over sorry, I said to type it in full. All right, no problem. So let's move on because of time. Number 2E, before increasing the dose of enalapril, angiotensin receptor blockers. Thank you, Edu Giffit. So thank you, Matthew Precious. All right, so let's move on. Before increasing the dose of enalapril, name 2 essential laboratory tests that must be checked. So now, before first of all, let me make a comment. You know, ARBs, we allow the conversion of angiotensin 1 to angiotensin 2. So ARBs definitely will not lead to the accumulation of bradykinin because it does not inhibit the ACE enzyme. You understand? So it leaves the ACE enzyme. The ACE enzyme breaks down bradykinin for its own reason, and then so it just only blocks the receptor. By explaining it in class, the angiotensin receptor blockers only block the receptors, while every other thing are working fine in that part, in the RAS pathway during the class. All right. So the laboratory test that you can do before increasing the dose of ARBs or ACEIs, you first of all monitor the creatinine level. Any kidney function, just write kidney function test. So you can do monitor potassium level, and then basically heart rate and blood pressure. You know, definitely potassium is fingered in contraction of the heart. I told you. So definitely you want to also measure the potassium, the heart rate, blood pressure, and then creatinine level. So those are necessary tests that you do before increasing any dose of AC inhibitors or ARBs. So that's that for that. Let us go to question 3. This question 3 is going to test us on an ARBs, angiotensin receptor blockers. So let's wrap up fast. We have just 2 more questions to go. Ms. Ngozi developed a persistent cough for lisinopril and was switched to losartan. So when you are looking at questions like this, the first thing you should do is sort of identify their classes. Don't just complete the questions, just identify their classes. Ms. Ngozi developed a persistent cough on lisinopril. Exactly the same question we did in number 2, and was switched to losartan. Lisinopril is ACE inhibitor. Losartan is an example of ARB. The sartans are examples of ARB. She asked the nurse why this new medication would cause the same cough problem. So now she's not asking the nurse, oh, nurse, I've been coughing from lisinopril. Why do you think this one will not cause? So explain the mechanism of ARBs and differentiate them. Obviously, we already answered that already. ARBs are receptor blockers because they will not alter the concentration of ACEIs. Okay. do not alter the constitution of ACE enzyme. They will allow the ACE enzyme be in the body so that the ACE enzyme will be able to break down the bradykinin. All right. Then, why do aerobes not cause dry cough? I've explained that already. NIP2 advantage of aerobes over NIP2 advantage of aerobes over ACE, because there's no dry cough. They are more tolerable, little side effects, you understand, and they're also once daily. Okay, even if ACE are also once daily. All right. So that's that for that. Then stage 3 conditions in which aerobes are indicated: hypertension, heart failure, diabetic neuropathy, chronic kidney disease. When I'm going to be teaching you diabetes, I'm going to mention is aerobes there. Okay, I'll tell you the functions of aerobes when I teach you endocrine. I'm going to teach you endocrine pharmacology. All right, so that is that for that. Let's go to question 4 quickly. So this question 4 is going to test our knowledge on calcium channel blockers. Now, in calcium channel blockers, I told you that calcium channel blockers are also classified as vasodilators. That is, they can increase the size of the vessels. So remember the pipe theory I gave to you in class, the pipe, where if there's a lot of if the pipes that connects to a overhead tank, those of you in Neighbor will say, listen to me right now. You know, when the pipe connected to that tank is wide, the water is not going to is going to be more in the pipe than going to be in the tank. But if the pipe is tiny, it's tight, you see, fewer water will be present in the pipe than in the tank. All right. So now, if we are going to be talking about vasodilators, you know, when vasodilators are taken, it means that the vessels are dilated. That's the interpretation. Vasodilators. So the vessels are dilated. More water from the tank enters into the pipe. In this case, more water, blood from the heart enters into the vessels. You see, the heart no longer have too much work to do, because why? More blood are present in the vessels going around. All right. Then I also told you that calcium channel blockers also have a way to act in the heart, to cause contraction. So when they are taken to block calcium channels, they will reduce contraction, because why? They are blocking the channels from working. So now, in that explanation, I know I must have missed this information, that they are divided into two. Calcium channel blockers are divided into two. So there is one class of calcium channel blockers. That class of calcium channel blockers is that they block only smooth muscles. All right. What they call selectively block only smooth muscles. Okay. And that class, they are usually known as dihydropyridine calcium channel blockers. They only block smooth muscles. They widen it. That is, this class of calcium channel blockers, they only work in the pipe. They don't work in the tank. They don't cause contraction of the tank. All right. Because that day I remember telling you that calcium channel blockers can be classified under vasodilators and under contraction, increase and reduction of contraction, like we are classified beta blockers, beta cells, and the AV and SA node, electrical impulses. So these calcium channel blockers, the dihydropyridine, we only block what? The pipes. While the non-dihydropyridine, we block both the pipes and also block the hearts. So non-dihydropyridines are non-selective. Then dihydropyridines are selective. So when the way for you to remember this is that non-dihydropyridines are non-selective, while dihydropyridines are selective. All right, please pay attention to that. That's the reason why I say this class is as necessary as the class I was teaching class, because case studies, we release so many parts of the coursework that is not even said in class. I know if I show you the notes that I have of cardiovascular pharmacology, it's up to 70 pages. Only cardiovascular pharmacology. So it is very important that you attend these classes for case studies, so that you'll be able to see them, apply the knowledge, because which is very necessary for your nursing council exam and for your practice. Okay, so back to the question. So the question says, okay, we've not read it. Mrs. Bola, 60 years old, started amlodipine 5 milligram. Amlodipine 5 milligram. Amlodipine block the vessels. They are what? The dihydropyridines. They are selectively block the vessels. So there is a vasodilator. All right. Daily for 2 weeks. She returns complaining that her ankles are swelling and her shoes no longer fit. Her BP is 136/84. So you should know why ankles will swell, because amlodipine blocks. dilates the vessels. So the vessels in our feet, the vessels in our hand, vessels in our leg, vessels in other parts of our body are increased in size. So blood can now stay more in those vessels. I don't know if I'm making sense. All right. So if I'm not making sense, if you have any question, please let me know. All right. Gift Didan saying come again. You want this come again? Okay, about the classes. All right. So let me say something about the classes. Fits. Listen. So calcium channel blockers can be classified as both vasodilators and classified as both reduction in contraction. That is, they can reduce contraction of the heart, but they can also widen the vessels. I told you that those are two ways with which we can control conditions of the heart. We can actually make the heart stop working as much as it used to work, which is by reducing contraction, or we can increase the vessels in the veins and the arteries so that more blood will be staying in the veins and the arteries and reduce the workload of the heart. Now, calcium channel blockers are a very unique class of drug in the sense that they can both fit in these two aspects of cardiovascular drugs. So the dihydropyridines of calcium channel blockers will block the vessels part, the vasodilation part. While the non, which is known for something to be non, means it's opposite. Non-dihydropyridines will block both the vessel and reduce contraction in the heart. So they will reduce contraction and they will also block the vessels. Non-dihydropyridines. Example are verapamine. Now, the dihydropyridines that will block only the vessels, example is amlodipine. I hope I'm clear. So the selective is the dihydropyridines. The non-selective is the non-dihydropyridines that can do both left side and right side, can do any of the two that you want it to do. So let's be fast. I have another class to take. So what is the unique mechanism of action of dihydropyridines? I've already mentioned. They dilate the vessels. So if I come to class again, I think your next week is your student week. There will not be classes, which is upper week. But hopefully I will schedule another class, online class with you, one of the evenings of this week, probably in the evenings or early in the morning. So explain why amlodipine causes peripheral edema, because it's a vasodilator. Peripheral edema means all the periphery, the vessels in the periphery are dilated. All right, and then it removes fluid from the capillaries to the interstitial spaces. When I come to class, I will explain that. Okay, because I need to show you a very small diagram for you to understand what that means. All right. So that's that. Number 3C. State 3 assessment findings that will help differentiate amlodipine-induced edema from heart failure. Yes, this is very important. You see, amlodipine is causing edema, but this edema caused by amlodipine is different from the kinds of edema that is caused by heart failure. In heart failure, the heart is not pumping very well. The heart itself is accumulating fluid. In amlodipine, the heart is not accumulating fluid. Where are the fluids present? I mentioned it in interstitial spaces. Because why? The vessels are dilated, more blood is now there, and those blood fluids cannot escape from those veins into the interstitial spaces. All right? It's not this one is greeting me good morning. You have not been in the class since. Blessing or money go. It's okay. So, in amlodipine edema, there is no shortness of breath. Why is there no shortness of breath, class? Because why? The edema does not affect the lungs. No, shortness of breath comes as a result of water or fluid gathering in the alveoli where there is gaseous exchange. All right? And all of that. There is no lung sound. There is no sound when the person is breathing. When people are having respiratory edema, it's difficult for them to breathe. All right? So those are part of the reasons why they are different. What is one pharmacological solution to reduce amlodipine edema? So now, class, in order to reduce edema, reduce fluid intake, in this particular case, it is good. It's not easy to add a diuretic, which is normally what everybody would do. If I ask that question, everybody's going to add a diuretic. No. What is going to help to reduce the edema in this case is to add an ACE inhibitor. An ACE inhibitor, remember I told you, ACE, ACE or ROB. This ACE inhibitor inhibits conversion of angiotensin 1 to angiotensin 2. ARB, it covers the receptors. Okay, what these two drugs, what they do is that they eventually have an impact in aldosterone. Remember, the system is called renin angiotensin aldosterone system. So they have an impact in aldosterone, which and aldosterone is responsible in the reabsorption of fluid. So when I come to class, I'm going to explain this mechanism very short, very brief, right? Because there's no diagram here for me to explain it. But the answer to this, in order to reduce the edema caused by amlodipine, which is the selective vasodilator in CCB, is by what? Is by using an ACE inhibitor. So now, quickly, question 4 or question 5. Okay, we just finished question 4. So question 5. Mr. Abraham, 68 years old with atrial fibrillation, is started on verapamil. So now, class, I gave you an example of dihydropyridines and the non-dihydro, blah, blah. Okay, yes, please, Faith, please remind me in class. I'll remind me in class. Or what you do, since, okay, do I have, I don't know if I will share this document with your class. If I share it with your class, you just copy that part of the question and send to me on WhatsApp. I will do a voice note. Before my next class, I will start with it with you, if that is okay. So for case 35, calcium channel blockers, which is in non-dihydropyridines. Mr. Abraham is 68 years old with atrial fibrillation. Atrial fibrillation is irregular perforation. That is when something fibrillates, means it goes going back and forth too frequently. That is irregular heartbeat. So is started on verapamil. Verapamil is both a vasodilator and what a calcium channel blockers in the heart that will inhibit the calcium channel and reduce the contraction of the heart. Do you understand? So this is a non-selective. So it means that this makes sense for a patient to be using for atrial fibrillation. Atrial fibrillation occurs in the heart itself. So he's also taking metoprolol 50 milligrams twice daily. 3 days later, he presents to the emergency department with severe dizziness and syncope. So this patient is taking metoprolol and verapamil. Now, metoprolol, who can tell me the class of metoprolol? Who can tell me the class of metoprolol? Egbe Augusta, your answer is correct. Yes. So say that non-dihydropyridine can be used to reduce the volume, not volume, contraction. Remove that word, change that word from volume to contraction. All right. CCBs have no business with volume. Okay. The ones that act that's a vasodilators, we reduce volume in the heart. Non-dihydropyridines are as one in charge with contraction. All right. So that's the answer to your question. Thank you very much. So thank you very much, Yusuf. Clemens, thank you. Beta blocker. So metoprolol is a beta blocker. All right. 50 milligrams twice daily. 3 days later, I present to the emergency department with severe dizziness and near syncope. So vital signs: 42 beat per minute heart rate. Blood pressure 88/54. So this blood pressure is quite very low. So now we're going to ask one question. State the 2 unique properties that differentiate non-dihydropyridines from dihydropyridines, which is verapamil, dithiazine from amlodipine. You should know that I've already explained that what serious side effect has occurred in this patient and what is the mechanism of action for this patient. So the serious side effect is what they call bradycardia, severe bradycardia. Now, let me say something, class. If a drug reduces contraction in the heart, like I've already told you for the non-dihydropyridines, they both act in the contraction of the heart and also causes vasodilation. And now a patient is not taking beta blocker alongside. Beta blocker, which metoprolol is, we reduce contraction of the heart too. So there are 2 drugs that are working in the same way to reduce contraction. So beta blockers and verapamil and the likes that reduce contraction of the heart. We give this patient bradycardia. So when they say state 2 unique properties, okay, I've done that. What serious side effect has occurred in this patient? Is bradycardia. You see the heart rate, you see the blood pressure. So sometimes combining these 2 class of drug will definitely lead towards fainting, which is what you see what they call near syncope, and sometimes death. And sometimes heart stop. The heart to just stop beating because why? You are inhibiting it from the calcium channel. You're also inhibiting it from the beta cells, and that can lead to trouble. I really hope that we are flowing. We are flowing with that. All right. So the combination is dangerous because you can't use it two together. They act in the same way. You understand? They are giving what they call synergistic effect, although this synergistic effect is not necessary. You are just blocking the two from the same route, and it's not necessary. All right. Question D: what is the immediate nursing intervention for the patient? Withdraw the drug. I always ask this question most times in drug interaction. Adverse effect: withdraw the drug. In which clinical condition are non in which clinical condition are non-dihydropyridine CCB specifically indicated? Okay. So what is the question talking about? The question is saying, in which condition, heart condition, will you use the non-dihydropyridines, and you are not supposed to use the dihydropyridines? To better put, in which clinical condition will you use the verapamine, the thiazine, and you are not supposed to use the what? The amlodipines and the nifedipines. Now let me tell you something. Any condition that has to do with the irregular beating of the heart, definitely you do not need the amlodipines and the nifedipines. Irregular conditions of the heart, what you definitely need are drugs that will definitely reduce the contraction of the heart, which is the non-dihydropyridines, because those ones, they also work in the heart and they work in the veins, in the vessels. So you need what will reduce contraction of the heart very well, so that what the heart will not be overloaded. All right. So that's that for that. We have a final. Yeah, precious. All right. So so please come and give me beta blockers and CCB. So beta blockers, the block that I told you, or I said it in class, that beta cells are in the heart. They cause increased contraction. Sorry, beta cells cause contraction of the heart. The calcium channel cause contraction. So now you have a drug that is reducing. You have a drug that is reducing the what they call the. You have a drug that is reducing the impact of beta cells. That's what they call beta blockers. Then the CCBs, the subclass known as the non-dihydropyridines, also what reduce contraction in the heart. So you can't use the two together. If not, you are going to reduce the contraction of the heart too much. Then it leads to a condition called bradycardia. You understand? So bradycardia just means slow heartbeats. All right. I hope you get that. If you don't get that, we should see in class. So that is that for that class. I think I have one more question. Well, this is the last question. All right, after this question, I'm going to give you a form to fill. Those of you that are not on, those of them that are not online, please, that form is going to be only be available while this class is going on. I'm not going to extend it. As soon as class ends, I'm going to turn off response for that form. That will be my attendance for this class. So case study number 6. This is for beta blockers. Mr. Tunde, 58 years old. This is the last case study. All right. Although I had 20, but I just made it 6 today. Maybe we'll be breaking it down so that we can grab them. Mr. Tunde, 58 years old, had an acute myocardial infarction, which is synonymous to heart failure 1 week ago. He's been discharged on metropolol 50 milligrams twice daily. Has a history of mild asthma, controlled with occasional inhaler use. Okay. The reason why I may not continue this is because I've not taught you asthmatic respiratory pharmacology. Respiratory pharmacology, beta cells are also present in the respiratory tract. There's what they call beta 1 and beta 2 cells. So beta 1 cells are majorly present in the cardiovascular, in the cardiac muscles. Beta 2 cells are present in the upper respiratory tract. When beta 1 cells, what they do is that they cause contraction. What beta 2 cells, they cause relaxation. Please note these two. Beta 1 cells cause contraction. Beta 2 cells cause relaxation. When you are blocking beta 1 cells, you are causing relaxation. When you are blocking beta 2 cells, you are causing contraction. What should say? I should repeat myself. This is very clear. Beta 1 cells on their own, they will cause contraction. Beta 2 cells on their own will cause relaxation. When you are not blocking them from working, it means that they will be doing the opposite of what they're supposed to do. So when you are not blocking beta 1 cells from acting, you are causing relaxation. When you are blocking beta 2 cells from acting, you are also causing contraction. So now, they already stated here that this patient have mild asthma. So now you are giving a beta blocker. And this beta blocker that you are giving is selective beta 1. Okay, that's what I say. When I get there, I'll teach it. Let's just leave it. All right, beta 1, which is what they call, not just like the way we have calcium channel blockers, right? One that is selective for vasodilation. Another one that is non-selective. In beta cells, we also have beta 1 selective blockers. We also have beta 2 selective blockers. Then we also have the one that are non-selective. That is, they can block both beta 1 and block both beta 2. Example of that is propranolol. Now, this one that this patient is taking is called metoprolol. Metoprolol are selective beta 1 blocker. That means they will block beta 1 cells. That means they will block beta 1 cells. All right, that's metoprolol. Metoprolol will block beta 1 cells. So when metoprolol block beta 1 cells, it is okay. However, when you increase the dose of these ones that are selective beta 1, they will eventually go and start blocking beta 2 cells. So that is the logic behind this case study 6. So please, I will begin from this case study 6 when I teach you respiratory pharmacology. Okay, so that is that for that. Success also say aneto. Please, sir, in the respiration, where beta 1 cells located in the upper respiratory tract, they are located there. All right, and they cause what? Please, sir, where are beta cells? Beta 2 cells. Beta 2 cells are located in the upper respiratory tract, not beta cells in general. All right, beta cells is their family name. Beta 1, beta 2, beta 3. There's only beta 3. Beta 3 is located around the GI tract and the rest. Beta 1, beta 2, beta 3. So beta 1 majorly in the cardiovascular system, beta 2 in the respiratory tract, upper respiratory tract, beta 3 in some other place. Now, when you take a drug that is called beta blocker, it blocks everywhere. You know, I taught you receptors. So when I taught you receptors, you should know that it will look for all the beta cells and block. As it's blocking all the beta cells, it is causing different reaction in all of these areas. So if it's blocking beta 1 cells in the heart, thank you, Yusuf. If it's blocking beta 1 cells in the heart, it's going to be causing what? Relaxation. If it's blocking beta 2 cells in the lungs, it's going to be causing what? Contraction. Then whatever function beta 3 cells, if it's blocking, it's going to be causing the opposite of that thing. So when there's a blocker, when you're saying the drug is a blocker, know that that drug that's a blocker is going to be stopping the natural thing that cell will do. Calcium channel blockers is going to stop calcium channel from working. So that is how that one goes. So when we do asthma, I don't know if I'm the one to show asthma, I will check. If I'm not the one doing it, I will come back to this question, start from here, we'll review the questions and start all over again. So that's that for that class. I really appreciate your time. See, I honestly do not want to put you through this. So please, does that mean that only beta cells are found in different stem? No. It does not mean that's only beta cells. There are plenty different kinds of cells. So, and I'm just telling you where these particular kinds of beta cells. That's what they call alpha cells. Alpha 1, alpha 2, alpha 3. Do you understand? So there are different kinds of cells. So when we get to their drugs, we'll start telling you all these beta cells are named because of the kind of receptors that they have. All right, guys. Sorry for distressing you this morning. This is going to be continuing because you see, we just exhausted 1 hour. I can't use this time for classes because class notes are much and bulky. So it's enough stress for me because I realized that most of your senior colleagues do not eventually complete their pharmacology syllabus. They do not complete it because there's so many things packed, and you are doing HND, so it's very necessary that you complete it. I do not want you standing before a BSc grad, a BSc nurse, and you are feeling inferior because you do not know. So I will do my part, create these case studies classes, and you just have to do your part and watch and listen. So this is going to be recorded. Thank God I was able to find an idea of recording it. So what you just do, that link, keep it. Whenever you want to refer to anything, go through it, read it. If you are even preparing for exam, my exams particularly, I cannot be giving you case studies and stress myself in bringing out a new exam questions. So you can go back here and read, study all the case studies so that you'll be able to know what to write. It will help you. All right. I'm going to drop a link right now for the attendance, and I want you to fill it in the next. Yes, you can rewatch the video later. That link that your class will drop on, you just click it. It will. I need to fill it in the next 5 minutes. These are 20 objective questions. Please do not spy, do not check. In fact, the higher you score, the lower your mark. There's a way I set the marking that the higher you score, the lower your mark. So I really want sincere responses from you. Fill it. It's going to judge if I'm going to repeat these questions later. This is not your CA. This is just for attendance. So as soon as you complete this form, whether you get 0, you get 1, you get 2, I am going to record your name as present. I'm not going to use the comment section because I realize that this video is going to be public. I don't want people looking at your mark numbers and the rest. That's why I told that other students to delete that mark number. All right. So thank you very much. And look at the link. I'm going to be on this call while you go and fill it. When you are done filling it, come back and say done, and then I will give. This is 8:0. What is the time? Time is 8 o'clock. I'm going to end response for that form in 5 minutes. So I need to fill it very fast, and I need you to fill it without checking any source of information. Because if you do not complete filling because you are spying and checking answers, I will end it from. Don't tell me, sir, I started at nothing. No, fill it very fast because everything I'm asking is going to be as already what I mentioned in this class here. Thank you. So that's the form. It's on the screen. So click it and go and answer. Hello, Dorothy. The link is on the group chat. Scroll up, you'll find it. Then the link is also on the screen. You can copy it from the screen or type it bit by bit. So I say the link is not working. Are you sure? Okay, the link is working. I've used it. I filled it. I will give it to one person to fill right now, and it started to work. It's working already. So please try again. Maybe your network is having problem. Those of you who are not seeing the link is because you are just joining the live stream. You are not joining live, so you cannot see the previous chat. So just scroll up and you will see it. Glory Oyedo said the link is not working. Please, I will give the link to your class rep to drop on the class group now. Daniel, please tell Daniel to pick it up. Meanwhile, I have just 1 minute with you. 1 minute more before the link is closed. So please, let me give it to Daniel. Okay, thank you very much, Yusuf. Yusuf has submitted. I've gotten so many responses already, you understand. So maybe it's network that is happening, and then ensure your Gmail is logged in because it will require you to fill your Gmail. But that's the screenshot I'm seeing that the class rep is sharing with me is definitely a network problem. It's not about the form. So probably you are having some network difficulty. Thank you, Saseri. I do give fit still not working. I do give. Where are you? Are you in the village? It's okay, no problem. Let me not waste time here. Because of those that are having network difficulty, I'll leave. Try to sort it out between now and 8:30. All right, because I'm going to use the responses from the comments from the. I'm going to use responses from the form. So I'll leave it now to 8:30. Try to sort it out. Maybe after you log out of the stream, it will work very well. All right, thank you very much, everyone. Thank you. I appreciate your time. And see you hopefully next week. I will let your class rep know what we can do next week and the day and time. Bye bye for now.